Welcome, everyone, to Rush University Medical Center Division of Nephrology Renal Biopsy Conference for September 28th, 2023. We've got a fun case today, Dr. Gashti's case. Hopefully we can have some more stimulating discussion. Our today's CME activity code is 489493. This conference is being recorded. They're all available on YouTube. Dr. Baxley puts them up pretty shortly, so please subscribe to our channel. And if anybody's not on our, I see some new names here today. If you're not on our mailing list, just send us a direct message, and we'll put you on the weekly mailing list. We do it about 2 out of 3 weeks of 2 out of every 3 weeks we have a conference. We have a lot of them recently because we're interviewing fellows, and I'd like to welcome the residents that are here and interviewing for our fellowship today. So welcome, everyone. We will not call on you. It's a free watch. As usual, patient privacy is being preserved by changing any identifying information, etc. And we'll get started with the protocol. This is Dr. Gashti's. I think, Casey, you're gonna present it.
Yes, I am. All right, so our patient is a 70-year-old female. She has hypertension, hyperlipidemia, reflux, and arthritis. She was admitted to our hospital with epigastric abdominal pain, nausea, and vomiting for 4 days. Her husband reports that she has been not feeling well and has not had much PO intake over the past few days. In the emergency room, she was hypertensive to 160/90. Her heart rate was 90, and she had a low-grade temp of 99.9. Her labs showed that her serum creatinine was elevated to 3.8, and she had a baseline of 0.9 6 months prior. Her CT abdomen pelvis without contrast showed that she had a thickening of the greater curvature of her stomach. She also had bilateral perinephric fat stranding. She underwent an EGD, which showed gastritis. She had a non-bleeding gastric ulcer, and she was positive for H. pylori. She was started on BID PPIs in addition to clarithromycin and flagyl. At the same time, her UA was also positive for protein, 3+ blood, 500 leukesterase, more than 182 WBCs, 87 RBCs, WBC clumps, and many bacteria. Her UA from a year ago was completely bland. Urine culture grew more than 100,000 CFUs of Klebsiella pneumonia. She was started on IV fluids, thinking that she was volume depleted, and also ceftriaxone, presumably for these urinary findings of pyelonephritis/UTI. Over the next few days, her renal function did not improve, so they consulted nephrology for further evaluation. Review of system: chills, nausea, vomiting, abdominal pain, and fatigue. Her past medical surgical history, as I mentioned: anxiety, hyperlipidemia, hypertension, reflux, arthritis, and vertigo. She's had cholecystectomy, hysterectomy, and a benign breast biopsy many years ago. She has no family history of kidney disease. She doesn't smoke or drink. She lives with her husband. She has 2 adult children that live out of state. She's allergic to lisinopril, gave her angioedema. She's currently on amlodipine, valsartan, atenolol, hydralazine, hydrochlorothiazide, Flonase, simvastatin, meclizine as needed, as well as ibuprofen as needed for arthritis. For vitals, she's hypertensive, low-grade temp of 99.9, slightly tachycardic, 154 pounds with a BMI of 25. She appears anxious, pale, and uncomfortable. She has a normal HE&T exam. Her lungs were clear. Cardiac exam is normal. She's slightly tachycardic. Her abdomen is tender to palpation in the upper quadrants. She has some flank tenderness on both sides, but with no rash and no low extremity edema. Labs that were available to us prior to her renal biopsy: she had a sodium 133, potassium of 3.5, chloride 98, bicarb 22, BUN and creatinine were 55 and 3.9. Her total protein albumin was low at 2.7, calcium adjusted was 10.7, bilirubin of 0.4, and her alk phos and AST/ALT were normal, so were her electrolytes, and her lipase was normal at 40. Her white blood cell count was 10.4 with 82% neutrophils, hemoglobin of 9.5, a normal platelet count, and normal MCV. Her viral serologies were negative. Her ANA was positive, 1 to 160, anti-RMP, anti-Smith negative, ANCA pending, complements 86 and 28 normal. Quantitative immunoglobulins, as well as SPEP and UPEP were all normal. Kappa lambda ratio was also normal. For your analysis, as I mentioned above, had protein and blood, normal glucose, 500 leukestrase, pyuria, hematuria, WBC clumps, bacteria, and a urine protein creatinine ratio of about 1 gram per gram.
Do you have a chest x-ray?
No.
Casey, you always have to read a renal biopsy was performed.
Huh?
You always have to say
Oh.
a renal biopsy was performed.
A renal biopsy was performed.
Any other questions for Dr. Gashti?
Casey, Mario, with that thickening of the greater curvature of the stomach, a biopsy of the stomach was not done?
They did. They found some gastritis. So they did some random biopsies. They found a non-bleeding ulcer and they found H. pylori. So they did do biopsies. And I will tell you later on that it was negative.
Thank you.
Did you have never mind. You've got it in there.
How many days before the biopsies was done and the antibiotics were on? It was one of the questions.
So antibiotics were started, the ceftriaxone was started when she first came in. We saw the first UA. The antibiotics for H. pylori was started 2 days into the hospitalization after her EGD. Biopsy was done, I would want to say day like 5 or 6.
What about a renal ultrasound?
So she had that CT that I mentioned above to look at her abdomen and pelvis, and she had 2 kidneys with perinephric fat stranding, but otherwise nothing abnormal in the kidneys on CT imaging. So usually the ultrasound is done at the time of the biopsy. So she did also have an ultrasound guided biopsy. So she had 2 different kinds of imaging and nothing remarkable.
So as usual, we're going to start with a poll. Good. So our poll is up, and this is a little different, but I'm curious what people think. What answer do you most agree with? And take your time on this because it's kind of complicated, but it's a little bit of an algorithm. Await the ANCA. I think it'll be positive, and then no biopsy needed. So you're going to await the ANCA. If it's positive, I got enough information. I don't need a biopsy. Number 2 is await the ANCA. It'll be negative, but then I need to do a biopsy. Number 3 is do not await ANCA, just biopsy now. Number 4, ANCAs take a while at Rush, but they don't take that long. So it won't be a week. It'll probably be a few more days or whatever. So do not await ANCA, biopsy now. Number 4, stop the hydralazine, get an antihistamine antibody and await results and make your decision then. Number 5 is await ANCA, it will be positive, then biopsy. Or number 6, this is AKI from pyelonephritis. Until proven otherwise, let's just wait. Let's just sit back, take a deep breath, and wait a couple weeks. Wait a week or 2 before we make any of this decision stuff. So which one do you like the most? Give it a little time.
Pretty good response rate so far. Let's give it a few more seconds here. Okay. Well, still a majority. Okay. All right,
So-
I'll end it there.
Edit there. Here's the results. So 60% say, don't wait the ANCA, just biopsy now. Interestingly, only 2 people said await the ANCA, it'll be positive, then no biopsy needed. So they're actually under kind of the impression that the ANCA is enough and we can wait a little bit. 14% said await ANCA, it'll be negative, then I need a biopsy. So the only reason I would really biopsy is ANCA's negative. A couple people said stop the hydralazine. Let's get the antihistamine antibody. This is probably hydralazine and kind of go from there. Only 1 said wait ANCA, it'll be positive, then biopsy. And there's a lot of options here. They get kind of confusing. The last 7 people said this is AKI from pyelo. Take a deep breath. Let's not jump into this whole thing. It's pretty straightforward case of AKI. until proven otherwise. So, one of the reasons I did this poll was because, more and more the last few weeks we've had a couple of cases of, well, did the patient really need to be biopsied? And that's always clear in retrospect. You're not there. Kind of one of the rules we've always had about in biopsy conferences, you don't ask why you did the biopsy. Because otherwise, we don't have biopsy conference if we don't do biopsies. And it's a little tough answering the question here when you in fact know that the biopsy was done, because it is biopsy conference. On the other hand, I hope that people can answer it, the way they would see the patient. Last week we had a HUS associated with diarrhea, and a lot of people said the biopsy didn't add anything. That's kind of, in the end, that might be true, but that doesn't mean the biopsy wasn't warranted. And it's a little, you have to be a little careful when you do that, but it's still, more and more we're getting to the point where some of these serologic testing, for instance, a lot of times it'll come up and it said, if you would have done genetic testing first, would you have biopsied this patient? Well, that's going to be, we're going to see more and more of that. Another situation is with PLA2R. There are situations where we may not biopsy patients who have positive PLA2R. And there's argument can be made in certain circumstances that's the situation with ANCA positivity. And again, and this is a little trickier because this patient has gotten a drug that might be related to that. So that's kind of why I threw this up. And I really don't like to have the discussion, why did you biopsy the patient? Because that's kind of unfair, but I think it's of some value to discuss what we got out of the biopsy and how much it helped you or not. But that doesn't mean it wasn't indicated or it wasn't helpful if it absolutely confirmed what you thought all along. So that's my little diatribe. And from that, let's have some discussion about the case. Let me hand it over to Bill. Bill, you off the golf course finally?
Off the golf course, into the lavender fields. I'm yeah, I'm all over. So yeah, that was a very good discussion. Thank you. And it was an interesting poll. I liked it. And that's the interesting issue is you're always thinking real time, what would I do? What is my differential in real time? Would I be doing the biopsy or not? And knowing it's biopsy conference and they got one, you makes you want to think about it. I think that I would have chosen to hold off. I would have said this person's pretty sick. They've got pyelonephritis. Likely it's going to be ATN. The urinalysis findings are terrible looking, but they're also terrible looking consistent with pyelo, and not necessarily a glomerular disease. And so always hard to sort that out. And that's why I can see going either way. I think common things being common, you would just call this, she's pretty sick. She's got some ATN and she has pyelo. But I can also see why the biopsy was done. So with that, if it's not going to be just ATN and pyelo, and by the way, I don't believe that pyelo itself, since it's just one segment of one kidney, that itself will cause renal failure. I mean, of course that would if you have a solitary kidney like a transplant. We see that all the time where pyelo causes AKI. Or if you have CKD already and your GFR is already low, then that may be knocking off that one segment might be enough to bump your creatinine. But pyelo by itself won't do it. But maybe the syndrome of pyelo and being sick and hypotensive, even though we don't have that, volume depleted, along with being on a diuretic and ARB, that would be enough to make her tip over the edge and have some ATN, as opposed to just being the pure one little segment knocked off. So I just wanted to point that out too. Because I don't want people to go home and say, oh, pyelo can cause renal failure by itself. It often won't be enough to bump your creatinine. So I think hemodynamic changes are pretty likely here. Like I just said, valsartan, thiazide, really sick. And I think that's most likely. And if it's not that, we've got, I think in the non-glomerular realm, we've got a lot of possibilities for interstitial nephritis that usually doesn't take off so quickly, with a rapid creatinine increase, but we don't quite know how rapid her increase was. The interstitial nephritis agents here, of course, you could think about a PPI, antibiotics, although she had a creatinine that was elevated prior to that. And then other issues, she has some mild hypercalcemia there, which I would just blame on her hydrochlorothiazide. But, you could always argue that she's got interstitial nephritis from an underlying sarcoidosis or granulomatous disease, which would cause the hypercalcemia with renal failure and give these urinary findings if they were sterile. Could it be, so that was interstitial nephritis. Could it be ATN? Could it be glomerular disease? yeah, I mean, she's got this mild ANA that's positive, but that's not really that anything exciting given her age. Hydralazine-induced ANCA-vasculitis is always pretty scary, so that's something to watch out for. That's already been discussed mostly in the poll, and we're waiting on the ANCA. I think that's mostly what I had on my differential here. And so if I had to kind of pick one thing, I would think sick person, pre-renal eating ATN, not quite opening up yet because of a lot of these medicines, and I would probably hold tight and not biopsy.
Great. I have a question back to Casey. On this urine protein creatinine ratio, do we have a albumin creatinine ratio? Do we know if this is glomerular or tubular?
No, I mean, the proteinuria was not, to me, that impressive. It was 1+ and 1 gram. So somebody who comes in with either AKI or CKD with those urinary findings with infection, I didn't really pay too much attention to the degree of proteinuria that was sort of low grade.
And certainly if this is all pyelo, I mean, there's a lot of white cells, and you can see white cells in GN, but I mean, you look at this as an internist, and this is pyelo. But my question was specifically to help us determine, since kind of our DD here is a GN versus a tubular interstitial disease from, say, pyelo or an interstitial nephritis from the PPI or whatever. Do you have an albumin creatinine ratio to compare to the?
Nope.
No, okay. Okay, and the dipstick had 1+ blood, and so that doesn't help us either, or 1+ protein. I'm sorry, and that doesn't help us either. I want to ask Dr. Rubin. Mario, do you remember which option you picked in this case?
Well, going back to the biopsy, I mean, frankly, I don't understand what's going on with this pandemia of a wooden biopsy. I mean, a kidney biopsy, till we get 100% reproducible liquid biopsy, and we don't have it, has diagnostic, prognosis, and therapeutic value. And I will be happy to discuss with anybody the prognostic value of the kidney biopsy last week. But in the meantime, this patient appears to have a nephritic process. She lacks the peripheral edema, but otherwise has hematuria, hypertension, and a UPCR of 1. And the differential diagnosis of nephritic syndrome should be entertained. And I don't have much to add to what Bill already said. To me, the most likely diagnosis is hydralazine-induced ANCA-vasculitis in this case. Certainly, as you pointed out, white blood cells can be seen in GN, so that doesn't shut me off. And to reinforce what Bill has said, acute pyelo does not lead to acute kidney injury unless you have one kidney. And I've seen it in transplant patients and in those patients as well, born with one kidney, but with 2 kidneys is unlikely. That's all.
Yeah, I think that's fair. But I mean, if you have a septic syndrome, you can certainly have renal failure. But your point's valid. And I would just say, yeah, it's a nephritic sediment, but this is also a pyelo sediment. It's an infectious sediment. I don't know you can make as much out of this sediment in the setting of this UTI. But you can also take the approach that you never want to miss RPGN and assume anything else. And so RPGN, if there's any question of RPGN, it's RPGN until proven otherwise. And for Bill, you're not saying you would never biopsy. You would just say you would take a deep, kind of what I was saying. You would just take a deep breath.
Kind of see how she does. And, I know she's been getting worse already, but ATN can sometimes do that too.
Great. Dr. Reen, one of the options here was, biopsy. No, but if you get a positive ANCA, you could not feel the need. You'd feel the need not to biopsy the patient. And this is a very specific question. Have you ever had a situation where you were convinced enough clinically, and the ANCA was positive, that you just, as you would with a PLA2R membranous, you didn't biopsy the patient? Have you ever done that, Dr. Reen?
I actually had a patient recently who actually was positive ANCA, and clinically we were very convinced that it will be a ANCA vasculitis, and we didn't biopsy her and treated her as such. So to me, if ANCA is compatible with the clinical picture, I'm not sure biopsy is needed. And that was also in PaviVax studies, which was done, and they didn't do biopsy in all the patients. So to me, biopsy is not that necessary, but I would like to add interstitial nephritis, as Dr. Whittier said, that generally creatinine wouldn't take off. But if it is a anti-tubular deposition disease, which can happen in rip-roaring interstitial nephritis, creatinine can take off.
So,
I hope I answered your question.
no, you did. You absolutely answered my question. Because I mean, I think, we're moving more and more away from, using not indirect evidence to avoid a biopsy. And I hope we never go too far. But on the other hand, biopsies are not benign either. And there are situations that are defining themselves more and more, some of these genetic things. And I certainly I don't know where we sit with vasculitis. I think it's a very controversial. Mario, have you ever not biopsied somebody because the ANCA and the clinical scenario was so strong that you thought you didn't need it?
No, absolutely not. And again, we keep forgetting about the prognostic value. Who is to say that this lady, older, with long-standing hypertension, does not have advanced glomerulosclerosis and IFTA? We know that both the glomerulosclerosis and IFTA not necessarily correlate with the serum creatinine. So if I biopsy and I find that at 70, I may just stop the hydralazine and not employ immunosuppression, for example. So to me, again, as I said previously, we don't have a liquid biopsy yet.
If I could just also take the opposite approach of what you said there, Dr. Robbie, which is I've actually biopsied a patient who had a positive ANCA and AKI, and they were on hydralazine, and the ANCA was very high titer, and all the biopsy showed was ATN. And so the hydralazine was causing the serologic test to be positive, but it wasn't causing renal vasculitis. And so that was very helpful. We spared the patient in the setting of an ANCA from getting rituximab.
Yeah, I think, this whole discussion, I remember years ago, and I know Dr. Glassick's, I don't think he's on, but when the ANCA first came out, I remember that whole discussion about the ANCA is enough. You don't have to do a biopsy. If it's ANCA positive, just start treating them. I mean, and we're talking a long time ago that this whole issue of using the ANCA alone was good enough. But I mean, I think the urovasculitis group has been very, it has added a great deal of insight into the histologic value of the biopsy. I mean, they've got their own, classification of a biopsy in somebody with ANCA vasculitis, not unlike what we have in lupus, with prognostic significance to the various combinations of lesions that you can find. And I don't know that there's any way to predict that from the ANCA alone.
So, Steve, what do you think this patient has?
I have no clue.
Yeah, of course.
No, I like Bill's differential. I mean, I think it was.
Yeah. Give me a 1. What's your top choice?
Well, I'm going to talk for a few minutes since you gave me the option. I think the issue of sarcoid is kind of interesting. Until I saw it was the adjusted calcium, I kept thinking, well, the calcium's 11.6 with the albumin being what it is. But I think sarcoid's a thought. Truthfully, I thought this is going to be some sort of an interstitial nephritis, to be honest. I think ANCA vasculitis is definitely in the differential, but with all those white cells, and everybody keeps talking about this person having pyelo. They're not febrile, they're not hypotensive, their white count's not that high. I mean, why isn't this just an urinary tract infection? We're all going down the rabbit hole of pyelonephritis, and I completely agree with Bill and what Mario said. People with otherwise normal renal function, which she had, who have pyelonephritis, which, as Bill alluded to, is basically segmental, because when it heals, you can see radiographically they have these little segmental scars. Those usually don't cause acute renal failure unless they're hemodynamically unstable, which means they're septic, if you will, which I think someone else brought up. So I don't know that this is pyelonephritis and not just an urinary tract infection. But that said,
Praveer, you saw this patient on admission. How did she look?
She looked like, she had flank pain, she had fever, she looked like she had pyelo, and I guess that, and she did not. Otherwise, it wasn't just a UTI to me when I saw her.
Okay.
Well, what was this? I guess maybe I misread what was described, but
she had flank pain on exam,
if she did have pyelo, then again, I still agree with the Bill that usually doesn't by itself cause renal failure unless it's a solitary kidney, somebody with renal insufficiency to begin with, or someone who has hypotension or hypovolemia. Anyway, I'm gonna, number one on my list is interstitial nephritis, whether it be from some granulomatous disorder, or in this case, a PPI, which she'd been on, and then the other is vasculitis, either idiopathic or drug induced due to hydralazine. I mean, she's not on that much hydralazine, but as we all know, that it's idiosyncratic. It doesn't really matter how much you're on or how long, it can still happen, even though some people suggest that it's more likely in higher doses and longer durations and people that are, slow acetylators. But that's the other thing too, is this ANA could be a result of the hydralazine as much as anything else.
And not to, another real question is, would you do empiric solumedrol? And that would give you a big answer here too, on whether you think, how strongly you think that this person has an ANCA vasculitis or not.
And how strongly you think she's got pyelo.
Right. So that's a big difference.
Can I interject a piece of history? For the old timers will remember the antibody-coated bacteria test that about 15, 20 years ago, there was an explosion of this test to diagnose pyelo, useless. But a piece of history for those that don't want to pursue diagnosis further. The other thing is, pyelo, much like rejection of a kidney, gives you a large kidney, a swollen kidney with prominent renal pyramids, and an astute radiologist will show that to you. So that was not here. Casey said the x-rays were fine, both the CT and the ultrasound. I don't think this is pyelo.
What do you think it is, Mario?
ANCA GN due to hydralazine.
Now, my only argument that I would, or whatever, is that typically when we see ANCA, hydralazine-induced vasculitis, the titers are very high and they're often varied with. Now, the patient does have a little bit of ANA, but the double-stranded, I believe, was negative, and the MPO is really not that high, and the complements are normal. Now, what we don't know, those are the ones that often get reported. That doesn't mean that hydralazine can't do it with a low titer. Does that sway you, these lower titers, Mario? Does that sway you away at all?
No, and I think Bill was right on the money when he pointed out that in many clinical instances, true and unrelated. I mean, you may think that you have a diagnosis, you do a biopsy, and it's totally different. So no.
Oh yeah, we don't have that. Okay, so let me ask Dia. Dia, real quickly, do you have you ever found a patient with an ANCA so high that you wouldn't biopsy the patient?
No, I don't think so. I think I'd biopsy them all. And I think that from some of the vasculitis patients I've taken care of at different courses of their ANCA in particular, I think it sheds a lot of light on what's potentially going on with them. And again, to what Mario said, I mean, I think in those cases, particularly at high ANCA and you have rheumatology involved, I really hesitate with some of the immunosuppression if there's scarring in the kidney. And the lady's 70 and her creatinine's 0.9, but that doesn't mean, I mean, that's, her EGFR is probably not 100 with that creatinine of 0.9 from a year ago. So I would biopsy with a really high ANCA, because I think we need to know what we're dealing with. And I think it gives some prognostic information too, that you can give to the patient potentially. And to go on if they don't get better, right?
A normal EGFR in a 70-year-old is not going to be 100 anyway, right?
Well, no, you're correct. But there's going to be probably some scarring in general, right? But I think that it would help with, I think it's also going to help with something potentially down the line. If you do have to treat with immunosuppression, something comes back, right? I think that, so I would definitely biopsy even if the ANCA is high.
One of the arguments that we would always, like, someone comes in with really bad lupus and it's pretty clear what they have. And one of the arguments, at least 20, 30 years ago, is, well, I can't give them cyclophosphamide unless I can justify it by knowing what the pathology is. And that's a whole nother argument that we could, which not today, but I'm not so sure that's always the case either. That because you could, clinically, there's often enough other things to justify the therapy. Mario, you were, no?
Well,
Doc-
you know, I was trained, and Jim Bello was my senior fellow when I was undergoing training, and I had followed his work closely. And I think the NIH, both Jim Bello and Howard Austin taught us, was the activity and chronicity index. They're very useful. And without a biopsy, how would you know? You need to do the biopsy. Furthermore, I'm now blanking on this gentleman from Ohio State that is writing in lupus.
Brad Rovin.
That's exactly right. I mean, he and his colleagues in Argentina have also taught us recently that there is no correlation between serology and histology in lupus nephritis. So, my dear colleagues, I am a firm believer in a kidney biopsy.
Dr. Reen, what does this patient have?
If you have ANCA positive and you have your lung findings and few other findings consistent with the vasculitis, how difference it makes if we do biopsy or not in the management of the patient? I can see kidney biopsy if you are thinking about renal limited disease, then the biopsy is indicated. But if it's a full-blown vasculitis, I'm not sure a biopsy will add anything. You just go ahead and treat the patient.
I think the prognosis part is something you can't forget. I mean, it really depends on the case. I mean, we know this patient had a normal creatinine 6 months ago. What was a patient who had relapsing vasculitis, let's say, and then you're determining if she's this patient is relapsing, and then you're going to give potentially Cytoxan or rituximab. I think having a prognosis is and kind of a chronicity, I think, is the important part of why the biopsy would be done, to me.
Dr. Reen, what does this patient have?
I have two diagnoses: interstitial nephritis, and it may, because his ANA is positive, if hydralazine is a good bet in that, if ANCA comes back positive.
So you're going to say it's a vasculitis, but you think it's hydralazine induced? Okay.
Yes.
All right. Let's get to the pathology. See who the wheel's going to pick. I had no idea I was creating such a controversy. I like it though. Mario's going to drive up to Canada and
Maybe we change the wild card to Dia. I don't know.
Oh, I don't know. I can't not without a,
Don't run away, Dia.
not without a warning.
If we ask the wheel, I think that the wheel will say we need a biopsy.
Well, Casey can't. There's twice for Casey, so he can't read his own biopsy. Sub is gone, so it's going over to Neelam.
The wheel has spoken.
Yeah, I kind of cheated. I didn't want to spin it 4 times.
All right, give me a second, Neil.
Kind of cheated.
Saba thinks the wheel has it out for her, so don't tell her that it went on her anyway. The wheel does pick on people. I have to agree with that. I don't know.
Gotta check the back, make sure it's not weighted.
Yeah, that's between us.
Yeah, don't.
The wheel is a bully.
That's our little secret. The wheel is a bully. Absolutely.
So Neil, can you
Can you hear me?
Yep, perfect. And then give me a second here. I'm going to give you control.
Neil's one of our
there's a
second
lag.
year. Neil's one of our second year fellows. So
Go ahead and click on the screen. Yep.
Okay. So here we have the trichrome stain at low power. It looks like we have a few
Before you
glands.
describe what one core is cortex, one is medulla. Can you tell which one is which?
Yeah, the one on the right side looks more like the medulla, whereas the one on the left looks more like the cortex.
Yep, good. You can even see one glomerulus there on the left also. Yeah.
Otherwise, for the most part,
This reminds me of Tom Jones when he used to sing the green, green grass of home. This is the blue, blue grass of home.
We're speechless, Mario.
On the cortex side, it looks like the tubules are fairly back to back. I don't see that much blue staining material, maybe like 25 to 30%.
Yeah,
of
yeah,
this
good.
was-
That's what I estimated. Yep.
We'll comment on the gloms at the other slides. Okay, this is the H&E stain with one glomerulus at high power.
You absolutely need a biopsy.
So the basement membrane looks, the Bowman's capsule looks intact. This part of the glomerulus looks normal to me, but right off the bat, you can see a lot of like just debris on this side of the glom, with some like extra pink staining material with probably like the fibrinoid necrosis. Is this like an early crescent right here?
Yeah, right. So yeah, so what are you describing? What kind of lesion? Yeah.
Like a crescentic.
Okay. Yeah, a
Necrotizing
necrotizing lesion.
lesion?
Yeah. Acute necrotizing lesion. Yeah, good. Yeah.
Very good.
Fibrinoid necrosis, karyotic debris, and then yeah, early proliferation of parietal epithelium forming a cellular crescent there, like you pointed out. Good.
David, I recently had an interesting comment, and I'd like to know your thoughts. In the assessment of glomerulomegaly, we used to use Bowman space. If it's all occupied, like in here, we barely see anything. That was suggestive of it. But recently I heard the pathology saying that in the 40X view, if the given glomerulus is bigger than half of that picture, that suggests glomerulomegaly. What are your thoughts in that regard? It's an obsession of mine trying to learn.
So I don't use pictures. I use, my actual objective while looking at the case. If it occupies more than the 40X field, then that corresponds with glomerulomegaly. But it's hard to assess from a photograph because they're taken at different objectives. So you really need to be at a microscope to tell.
Thank you.
Okay.
So the answer still is yes. It's just.
Well, for example, this is, this is not a 40X image, but so yeah, like I said, I'd like to use my microscope to tell. But I don't think this one is particularly enlarged, since we're on glomerulomegaly.
All right, Neil, take over.
Okay, moving on to the next slide. Here we have the PAS stain with, again, one glomerulus at high power. Is this a break in the Bowman's capsule right here? Is this just a staining-ish?
Yeah, no, that's not a true break. We'll see one on the next slide, but that one's okay because you don't have any disruption there and inflammatory infiltrate.
Is it the takeoff of the proximal tubule? Because it looks like there's a brush border there.
Yeah, could be, Steve. Yeah, good observation.
This looks like potentially another like crescent, a cellular crescent, maybe, or
No, that's glomerular tuft where you're on.
Oh.
Yeah. But what about in the middle? What's going on in there? Yeah.
There's again some fibrinoid necrosis or like just breakage.
Yeah. So another destructive necrotizing lesion. The bright pink is fibrinoid necrosis, and then the little black dots, karyotic debris, nuclei breaking apart. So second glomerulus with the necrotizing lesion.
Yeah, the idea here is that this is there's a break in the membrane with dead cells, and those become little dots of karyotic debris, and then this big blob here in the middle is it's fibrin pouring out into Bowman space, which we may or may not be able to see on immunofluorescence if we catch the right glomerulus. But
otherwise the tubules here
looks like there's some loss of brush border
Yeah.
on the left, so some ATN.
Another glomerulus on the PAS stain at high power. Here we definitely see a cellular crescent right here.
Yeah. And Bowman's capsule looks disrupted also down at 6 o'clock on this one. Yeah, now that's real because you could see the fibers breaking apart and there's an inflammatory infiltrate down at the bottom.
Okay. Otherwise, there's some ATN that you can appreciate in some of these tubules on the left as well, I think.
Yeah, so now let's look at an uninvolved glomerulus on the next slide. Oh, whoops, one more.
Here's the Jones and Silverstein with, again, another glomerulus. Here, I would say the Bowman's capsule, from what I could see, looks intact, but right off the bat, you can see some breakage in the basement membranes with some debris on this part of the glom, and then otherwise looking for spikes or holes along the basement membranes. I don't really see any of those on here.
Okay. Yeah, so on the top left, you have some preserved tuft there with open loops. Yeah, no spikes or holes. And then you pointed out the ruptures, fragments of basement membrane, and that's a crescent, a nice, that's all parietal epithelial cells.
Neelam, earlier in one of the slides, you picked the left side as the crescent, and David said that was a tuft. I mean, in your defense, it's not always that easy. It was pretty destroyed. It wasn't that always easy for me to tell which side is the crescent and which side is not the crescent when you got fibrinoid necrosis in the middle. This makes it pretty easy here. You can see where there's capillary loops on the left and nothing on the right. But clearly from that slide, you could tell whatever disease it is, it was very segmental, and you got half and half. But this is really quite easy, as you pointed out, and you can see the pieces of basement membrane floating around in that crescent. So you may not even find the break, but you know there had to be breaks because of the remnants. I'm sorry, Mario.
No, that's fine. David, I think this picture is useful to the fellows and young individuals in the audience for them to be taught the difference between a crescent and a pseudocrescent on the basis of the number of layers of cells in the crescents. Could you please comment on that?
Right. Yeah. So a crescent typically is defined as 2 or more layers of parietal epithelium that involves more than 25% of Bowman space. And so clearly here you could see layers upon layers of cells forming a nice crescent. I try to stay away from the term pseudocrescent because, when there's ruptures and fibrinoid necrosis and early proliferation of parietal cells, I like to say there's early crescent formation, but I don't really use pseudocrescent. We haven't really used that in our biopsy conferences. I think it's just confusing to the clinician. Well, is it or is it not? It's pseudo. What does that mean? So.
Right, but other people practice elsewhere and they are going to hear that term, so it's good to know. So thank you for your teaching.
Hey, Mario, in terms of the pseudocrescent, is that what you typically are seeing? Which in the in like the collapsing variant of FSGS? Is that
that's true? That's
okay.
true. I think there is a comment in the chat now, exactly that, from Arun, mentioning the collapsing story. Yep.
Well, there's no question this is a whopping crescent. Nothing pseudo about this one.
This is just croissant.
So here we have the PAS stain again with one glomerulus. Here the basement of the membrane the Bowman's capsule looks intact and the capillary loops look all open. Here I don't see any of the necrotizing lesions that we saw prior. I think this is the normal glomerulus you were referring to, Dr. Singleton.
Yeah. Yeah, so it looks okay, huh?
Mm-hmm.
What about that vessel on the left? Anything there?
like this one.
Yeah. Yeah, you
Ah.
have an interlobular artery there. You see anything?
It looks thickened, I guess.
Yeah, some mild arterial sclerosis. Yeah, mild fibrointimal thickening. But no vasculitis there or rupture of the wall or anything like that. Let's see, what percentage of glomeruli had crescents? 3 out of 7.
Okay. Looks like the immunofluorescence was negative for IgA and G and IgM.
Yep.
Both. But was positive for the fibrin.
Yeah, so you see there right off the center of the middle, so that would correspond with one of these necrotizing lesions we saw in the light microscopy, the intense staining for fibrin. And then we didn't get a glom for EM.
So Neelam, what's your clinical, your pathologic diagnosis rather?
I guess like posse-immune necrotizing GN with some ATN.
Crescents.
Very good.
So
Yeah,
what
very
percent, how many of the other 4 glomeruli, were they normal or were they scarred or what?
So 7 gloms on the light, 3 with the necrotizing lesions, 1 globally sclerosed.
On advance. So, Casey, or
Yeah, so this is initial follow-up on those serologies that were pending. So her antihistone was positive and her ANCA was also positive. But the p-ANCA was much higher titer with an MPO level of 5.9. PR3 was normal.
all right, so I think we have a poll here. So at least now we have a ANCA positive posse-immune crescentic glomerulonephritis. What would you do now in addition to stopping the what we now call hydrankazine, because it's so commonly seen as a cause of vasculitis in our practice? Would you use rituximab-based regimen, cyclophosphamide-based regimen, avacopan with either 1 or 2, plasmapheresis followed by either 1 or 2, or a combination of 1 and 2, the kind of what we call the Niles protocol from Mass General? That is where they use rituximab and low-dose cyclophosphamide.
Well, this is going on. I think we have to be careful about whether we attribute this to hydralazine as the only cause for this, as opposed to somebody that just happens to have vasculitis and was on hydralazine, because there's no way to know for sure. And this ANCA titer is not all, it's not off the charts, as Niles had shown when they were looking at their series of patients.
Yeah, I don't think we're implying that we have any idea, but no one would. I don't think anybody would continue the hydralazine.
I don't think they would either, but the term that you're using implies that that's the cause, and I just think that's somewhat of a...
No, okay. The term is there because that's our fun name for
It's a
hydralazine.
fun name. Yeah.
Yeah, but we're not implying that we know that at all. In fact, I don't know the answer. My experience, again, is just when I've seen hydralazine associated with it, it's always very high titers of everything, and often other things, including hypocomplementemia. But that doesn't mean it has to be that way either. I think it may be a bias if those are the ones that get identified.
No, I agree. And I think there are plenty of cases where people were on hydralazine, had an ANCA that wasn't really high, stopped the hydralazine, treated them, and they continued years out to still have ANCA positivity despite being off of hydralazine.
Now, Steve, I thought that the classical paper on hydralazine associated ANCA vasculitis was by the Columbia group. And I think that some of those cases did not have a super high ANCA, did they?
No, but that's, if you're talking about Vivet's group in that paper, first of all, they didn't have a lot of follow-up on all the patients. And they didn't have follow-up ANCAs either. I mean, to me, the classics paper still is the one by John Niles in Boston, which preceded Vivet's paper. And in Vivet's paper, I mean, obviously most of these are retrospective, because I went back, I've been looking at that recently. I mean, it's really unclear what the course of these patients were with respect to their ANCA after the hydralazine had been stopped. And again, people that have persistent ANCAs that are positive, especially even if they weren't high, because like I say, you can have the association. It doesn't necessarily mean that it was induced or that hydralazine was the cause, as opposed to it just happened to coexist. That paper didn't really help me much.
I let Vivette know.
I can tell her myself. That's good.
Just what is it, Steve? The
Good-natured give and take of nephrology.
Good-natured give and take of nephrology. Yeah. Well, we're having a lot of it today. Dia, have you used number 5? I know that's very popular in Boston. Have you used number 5?
No, I haven't used the combination base.
To me, when I first read that combination regimen, I thought, well, this is because it's very severe. And I look at this biopsy and I'm seeing a pretty severe lesion, and I would think that maybe that's it. But really, when you read about, they've had two reports of that now. And basically, it's more of a steroid sparing kind of protocol than it's really severe, let's hit it really hard. I don't know how you separate the two. It may be steroid sparing, but it just seems to me when you add those two together, you're hitting it a little harder. Dr. Reed, what would you treat this patient with?
Actually, I'm going to go off the limb. Mine will be one and avacopan and rituximab, actually. That's what I will choose in this patient. Avacopan is my choice because creatinine is high, it can come down. So that will be my choice at this time.
Mario?
Well, unfortunately, I disagree with my esteemed colleague to the north. I don't think there is data on avacopan and dragging. So I would treat with rituximab.
Rituximab, okay. Well, for sake of time, I'm going to hand it back to Dr. Gashti, and he's going to talk about what he did and what his decision was based on.
All right, so here is the follow-up. So initially, we did start a rituximab-based regimen. She was started on IV Solimedrol for 3 days, and then we put on oral prednisone. We gave her rituximab, sent her home, creatinine of around 3.9. Her husband calls within a week. She's not really tolerating the steroids. She just had that gastric ulcer. She's not sleeping. She's very anxious. She has anxiety at baseline. She's muscles are so weak she can't even walk. She has significant edema. So we start on Lasix, 40 milligrams a day, and lowered to prednisone of 40. I see her in follow-up again in 2 weeks. Her creatinine is still stuck at 3.7. Still doesn't feel very well. Still having the same issues. So I lowered the prednisone further down to 20. And I was really not that comfortable tapering the prednisone that fast. So I did add avacopan 30 milligrams twice a day. And this was really sort of my introduction. This is the first time I've used this. And it was my introduction to complement blockade in treatment of vasculitis. So I'll go over that in a little bit. But when I saw her 8 weeks post-biopsy, most of her symptoms were gone. It was either the Rituxan kicked in and it was time, or the prednisone, she had enough of it and it was just lagging, or it was the avacopan that worked. I can't really tell you which one, but she felt great. The creatinine was a little bit better, 3.0. I was a little disappointed it wasn't much better, but I think the biopsy looked pretty bad. So I think this is going to take a little while. This is only about 2 months out. So next slide. I know we have only like about a couple of minutes. I just want to talk briefly about the role of complement in vasculitis. And traditionally, we don't think of complement having a role in vasculitis because it's not usually an immune complex mediated disease. It's post-immune, but complement activation has been since in the early 2000s implicated, because some of the biopsies of patients reviewed by Dr. Haas, Pathology, did show that at least half of those patients did have IgM and C3 at some point in the glomeruli and on EM. So it wasn't that these were purely post-immune diseases, but kind of going back to the complement cascade, starting from the animal models, if you look at the complement pathway, classic, lectin, and alternative pathway, they looked at whether blockade of complement could stop development of vasculitis. And in the mice model, when they do the knockout models, and they actually block C5. Prabir, can you give me control? Okay. So when you block C5 in mice, these are mice that are receiving injection of anti-MPO and they develop glomerulonephritis. If you knock out C5, they don't develop glomerulonephritis. So then you go further upstream and you block C3, they still don't develop glomerulonephritis because C3 is required for C5. And so you're trying to keep going upstream and see where, is this a classic or an alternative pathway? And blockade of C4, which is common in both lectin and classic pathway, those mice still develop vasculitis. So what this implies is that the complement activation in vasculitis is an alternative pathway, which is pretty much like your complement that's idle all the time. It's on all the time, and it essentially assists in reactivation of complement cascade, and not so much based on immune complexes or viruses or bacteria. And so the question was whether further down, was it the membrane attack complex? And the answer was that when they blocked C6, the mice still develop vasculitis. So they essentially narrowed down to the fact that it was one of these C5a or C3a that were causing ultimately the development of vasculitis in these animal models, and blockade of C5a, which is subsequently became the reason for development of C5 blockade, which is avacopan, came to be in humans and subsequently clinical trials. So the most sort of significant clinical trial is this randomized trial, essentially, which is the Advocate trial. And they randomized patients who had vasculitis, and these were both fresh ANCA vasculitis patients and relapse patients. And the breakdown was essentially 70% of them were newly diagnosed, 30% of them were relapsed, and 55% GPA, about 45% MPA. So these patients were randomized to either getting standard of care, which is either induction with Rituxan or cyclophosphamide, either IV or oral. And then the cyclophosphamide group got azathioprine for maintenance, and the Rituxan group did not receive any more than the 4 initial doses for maintenance. Or these patients were randomized also to getting prednisone along with Rituxan Cytoxan, or they were getting, instead of prednisone, they were getting avacopan. The truth is, if you actually go back to the appendix, some of the patients in the arm that was supposed to be steroid sparing, they also did receive steroids, but at a much lower dose. So the avacopan group was not steroid free, but they had a much lower average dose of glucocorticoid exposure. On average, over a year, they had about a 4 milligram per day as opposed to a 12 milligram per day in the steroid arm. And the results were pretty impressive. At about 6 months, avacopan was not inferior to steroids, and at 1 year, it was actually superior to steroids from a standpoint of relapse. And relapse was defined as once patient went into remission. Relapse was defined as hematuria, proteinuria, increase in serum creatinine, and also they had their Birmingham vasculitis score, which they defined relapse in. So it seemed like a promising drug in patients who either cannot tolerate steroids, or if you want the patient to be steroid not free necessarily, but at least less amount of steroids. So that was sort of the opening for me in this particular woman who was recently diagnosed with a gastric ulcer based on endoscopy, was having a lot of steroid-induced myopathy, was having anxiety and insomnia, that I had to drop her steroid very quickly, but I wasn't comfortable with the outcome of her glomerulonephritis to introduce avacopan. But I think going forward, I'm actually going to be more aware of introducing this earlier in patients that I anticipate. If somebody's a bad diabetic, I may start using this sooner than later. And if you look at the side effects, they were actually less infections, 30% less infections. The nice thing about avacopan is it doesn't block C5b. So unlike eculizumab or ravulizumab, who need to be vaccinated against Neisseria, this does not actually block C5b, so we don't have to worry about infection with encapsulated organisms. So infection rates were actually lower than the glucocorticoid group, and so were the other steroid-related complications in the avacopan group. So my sort of 2 cents here is that you should kind of have this in your toolbox of things that we can use for treatment of vasculitis as part of induction with Rituxan or Cytoxan.
Yeah, I think that's a good point. And you know, yes, it was presented for as a kind of steroid sparing agent, but it's hard to ignore the you know, the result differences. And and one thing we're learning in the last decade is that this just hitting people with steroids high doses forever is a thing of the past. We've been cutting down our doses. We saw that from Pexavas. There's lupus trials where they're using less and less prednisone, and what's allowing us to do this is more specific tailored therapy where you're attacking a very not hitting every part of the immune system. It's a shame because I'm not, you know, who knows how well all these are going to be studied. You know, there's you know, all these new drugs for IgA nephropathy, for instance, that are looking at things differently. And I think we're just going to see more and more and more of this. But hopefully we're going to get to, you know, more precision medicine. And we're not, you know, the old days where everybody got cyclophosphamide for everything and high dose prednisone for everything. And some of them died, and some of them died of sepsis, and some of them had shoulders and hips replaced from prolonged steroids, and some of them died of even pneumococcal or PJP pneumonia. I remember a case of that, a young woman with lupus who died of you know, what should be a preventable and treatable disease. So I think it's great that we're getting further along with this stuff and getting, you know, more targeted therapies. It's a shame this is so expensive. It's really a shame that all these new drugs are so expensive. And I think the pharmaceutical industry is going to do it as long as they're making enough money. But, you know, hopefully more drugs will come out and generics will come out, and maybe these things will be studied so that we can do exactly what you did. I think, Dr. Reen, what was your reason behind using avacopan initially? You're muted.
My reasoning was twofold, that as Dr. Bashti mentioned, that had some GI issues like gastritis or gastric ulcer. Moreover, I like using this drug in a couple of patients. If their creatinine is quite high, it can actually lower creatinine. So those were the two reasons where I use avacopan in this patient. GI side effects and creatinine was significantly high. And I think it is well mentioned in the literature that it can bring creatinine down a little bit more rapidly, and you can take the steroids off as quickly as possible.
And I know if Dr. Glassick was here, he would actually challenge you very aggressively about there's no data to do what you're doing. And that's what Dr. Glassick does well. On the other hand, there's the argument to be thinking outside the box and don't be too rigid. Is it real expensive in Canada, or is it more affordable?
It's not that it is available for us on compassionate basis, so we are able to get it. I have used in a young patient creatinine of around 3.8. He didn't want to use steroids wanted to get off as quickly as possible. And actually that guy did very, very well on this. So I'm actually more excited about this drug than I see other people using it.
Have you used it?
2 of them, yes.
Yes, I have. I also have a conflict of interest or a disclosure for Amgen as doing some teaching materials and things for them. But yeah, I think, like Dr. Reen said, I think the mechanism makes sense. And I think moving towards more precision targeting makes sense. And then there's some anecdotal data I have that it worked pretty well. I know that's not evidence-based in that regard, but I think in the same patients he's talking about using it, and some of the hospitals have been able to get it even for the severe pulmonary hemorrhage, renal failure, get it in the hospital to start then too. So
yeah, I think I've heard about that, where the pulmonologists have been using it early for a very severe case. And I don't know if there's data for that either, but I don't know. I like the idea of that, but you know, I can't support it. But I like the idea of trying new things and being more targeted and thinking outside the box. And
well, I think the FDA approval is for severe active disease, which in the cases we would see would be proteinuria and renal failure. So I think from our standpoint as nephrologists, from an FDA perspective, the approval is for use in those certain patients.
And Roger, you kept saying that the data is not there, you can't support it, but what more data would you want? I thought that New England Journal was quite good at showing equal efficacy at 6 months and then actually superior efficacy at 1 year. And you were able to get away with less steroids. I thought it was a very convincing study by Jane.
Point taken, Bill. I'm speechless, and that's rare.
Roger, I want to ask you a
Yep.
question. Dr. Green, you mentioned twice that avacopan decreases creatinine. Is that through the anti-C5 mechanism that Casey described, or there is something else?
It was described to me by a rheumatologist, but I've forgotten it. So I have to find that paper for you and post it after the conference.
There's
Sure.
some supplemental data, I think, Mario, that showed it in the subgroup analysis of reduction in creatinine. So there's some data in the paper. I don't remember the exact
Yeah,
number.
that New England Journal has a supplementary appendix that shows that the GFR goes down by about 12 in the avacopan group, but about 5 or 6 in the steroid group. So there was a more significant reduction in GFR in the avacopan arm.
I'm going to wrap this
Okay.
up because we have to do some interviews. But I just want to say one thing. When I was talking to Dr. Gashty and Dr. Baxley about the case today, I was a little worried that we weren't going to have enough to talk about. And here we went over a little even more than usual. So as is so commonly the case, we've got such a stimulating faculty. And I want to thank Dr. Wagaspak, Dr. Rubin and Dr. Reen for joining us and putting in their opinions well, as in addition to Dr. Corbett and Dr. Whittier. So thanks very much. We should be back next week. Hopefully I can get my case together. I've got a good one. And until then, we'll see everybody. Stay safe. And thank you.